Okay, so today's question is a little bit more general. Today's question is, how do you treat depression, right? So let's take a step back and see, what are the current available treatment options for major depressive disorder. I apologize. Okay. All right. So today's question is a little bit more general. Today's question is more open-ended of how do you treat depression? What are the treatment options that are available today for the treatment of depression? So the first-line treatment for depression is usually psychotherapy. Particularly, we're talking about cognitive behavioral therapy, interpersonal therapy, problem-solving therapy, dialectical behavioral therapy. So those are the major ones that are basically evident to be effective in treatment of depression. Think of cognitive behavioral therapy as a way of changing your thoughts, and when you change your thoughts, your feelings will change, and when your feelings change, your behavior is going to change. So if my thought is that whatever I do is wrong and I could not do anything good, right, then my feelings are going to be feelings of failure, feeling of hopelessness, and then my behavior is going to reinforce that by I don't want to try, I don't want to go out, I don't want to meet friends, I don't want to look for a job, etc., etc. And when my behavior is like that, then that would reinforce the thought again, because when I look at the mirror or when I'm looking at my life situation, I'm going to reinforce the thought of I could not do anything right? So we get into this vicious cycle of automatic negative thoughts, and that reinforces clinical depression. So we can do cognitive behavioral therapy to change the thoughts. So, somebody will examine their thoughts. Well, it's not like everything I do is wrong. There are a few things that I do that are right. Okay, well, let's write them down. And then you start writing, things of like, I'm a loving father. I care about my family, my wife, my children. I try, to kind of get better, and then you're making the list and it grows more and more. So when you look at your thoughts and you see the positives and negatives, then your thoughts are going to be balanced. And when your thoughts are balanced, your feelings are going to be balanced. So you don't feel completely hopeless. You feel more balanced of like, okay, well, I am sometimes hopeless and sometimes I'm hopeful. And then when you are having balanced feelings, then your behavior is going to be balanced as well. So sometimes you would go out, do things, try to do behavioral activation and enjoy life and what have you, and that will improve your situation over time. Okay, so the problem is that when it requires some cognitive abilities, and that's one of the symptoms of depression, that you will have cognitive impairment, right? So it requires some cognitive ability for you to be able to kind of comprehend those thoughts and, work on your thought process and what have you. The other part is that when somebody, it usually works for mild to moderate depression, and if somebody has severe depression, cognitive behavioral therapy or therapy generally would be a little bit less effective on its own. So we need to do something else, with it. Think of this similar to treatment of diabetes. If somebody had an A1C of 6.7, all right, you might want to take the chance of well, let's do that and exercise and then follow up with another A1C in about 3 months. A1C is the average, reflects the average of someone's blood glucose or blood sugars. So you could diet and exercise if you have mild case of diabetes, but if you have severe diabetes, if someone's A1C is 9 or 10, or their sugar numbers are running in 300 and 400s all the times, you can't just tell this patient to diet and exercise. You're still going to do it, but you're going to add medications, right? You might need to use insulin in this situation, right? Mental health is no different than physical health. It's the same thing, right? So with clinical depression, you need a comprehensive approach, okay? So somebody with severe depression, somebody who's suicidal, somebody who attempted to end their lives, that's obviously not a normal cognition in there, right? That is somebody who will need CBT, will need therapy, but in addition to therapy, we might need to start medications then. Then that's when, SSRIs and SNRIs and all those medications that you see around and they're overly prescribed sometimes, come to play, right? So we prescribe an antidepressant, okay? So what happens then? So if you are prescribed an antidepressant, we want to wait some time to see, how effective it is, right? So we were waiting for about 6 weeks, sometimes a couple of months to see the effectiveness of an antidepressant. We need to adjust the dose over time, increase it gradually. The chances of somebody responding to an antidepressant and psychotherapy at the same time come up when they're together, come up to over 40%. We're touching about 50% then. But if we're doing monotherapy of an antidepressant medication, we have about 1 out of 3 chances of response, right? And if somebody does not respond and we switch to another antidepressant, because that would be the second step in treatment, then that number goes down to around like 21% or so. And if that doesn't work out, then we go down to about 16% or so. And then if that doesn't work out and we're at the 4th medication trial, then we're around 6.9%. Remember, in stage number 3 and number 4, we also add augmentation. So augmentations are the like of antipsychotics, so that's when you see commercials, talking to like, if your antidepressant is not working for you, talk to your doctor about Abilify, right? They're trying to tell you that sometimes mood stabilizers could enhance the effectiveness of an SSRI or an antidepressant. So far there is nothing that you don't know already, okay? So you already know that we use antidepressants. We already know that the success rate is not the greatest, but it's not different than anything in medicine, right? Antibiotics, if your doctor is prescribing you antibiotics for a reason of infection, it's the same thing. Your best chance is with the first antibiotic. And if you're not responding to it and you have the bug that caused the infection is resistant to that first antibiotic, you will need a couple of antibiotics for the second course of treatment, and your chances of response might be less than the first trial. Okay. So what do we do then if somebody does not respond to medications? Well, that's when we call this treatment-resistant depression. And just for full disclosure, there is a medication that's FDA approved for treatment-resistant depression, which is a combination of 2. This is fluoxetine plus olanzapine. That's Prozac and Zyprexa combined in one pill, and that's FDA approved for treatment-resistant depression. But it's a gimmick thing, because that's what we do anyways for augmentation of depression. Labeling that as treatment-resistant depression and getting the FDA approval for that, doesn't mean much. But yes, that's a medication that's approved. Okay, the other medication that got approved recently for treatment-resistant depression, recently relatively, is esketamine, right? So ketamine had been used off-label for the reason of depression for a while. Esketamine is a derivative of ketamine, and it got an FDA approval in March of 2019. All right, but what other options do we have when medications don't work? Is there something that's not medication that could help? Yes. So the oldest gold standard for treatment-resistant depression, or for depression that does not respond to medications, or before medications even were a thing, is ECT, or shock therapy. Shock therapy is the terminology that people use, non-medical people would use, and I hate that terminology because it gives the impression that we're actually hurting somebody, which is not the case. ECT is electroconvulsive therapy, and I do understand the stigma behind it. I do understand the public opinion about ECT, but you deserve to know about the treatment options that are out there. So with ECT, we're bringing a patient to a hospital for an outpatient procedure, basically. The patient is put through generalized sedation as if they're going through a surgery or a procedure, and the psychiatrist is delivering electrical shock or electricity to that patient brain, either bilaterally or unilaterally. And that will induce a seizure in the brain. And that seizure should last for about like 3 to 5 minutes. About 3 minutes is the average that we see. And after that, patient is taken to the recovery room, and they wake up from their sedation and they go home, right? And we do that for about 2 to 3 times a week for about a month. And then after that, for about once to twice a week for about another month. And sometimes patients will need maintenance ECT to keep them well after that. ECT generally is currently not used as much for the reason of depression, again because of the public opinion about ECT. But it's still commonly used relatively commonly used for the reason of refractory psychosis or catatonia. So we have more guts to use ECT when things look obvious to the people around, like catatonia or refractory psychosis. When things look obvious that there is some kind of intervention that needs to happen, we don't tend to do the same when it comes to depression. That's a different discussion that we can have in future videos about ECT and why we have this opinion about it. Okay, but the facts are that ECT is effective, okay? Now, we can argue about the side effects of ECT and what are those and stuff of this sort. That's another topic as well, but ECT is effective. Let me mention briefly side effects of ECT. There is short-term memory loss that could happen with ECT. Somebody could forget what they ate the night before, what they have, or how they got to the hospital, what have you. Less commonly, patients could have long-term memory loss. A little bit, I had patients who would say, a few months, 4 months, or what have you, or how they, a period of time during the depressive episode, they don't have clear recollection of what happened there. And there are sometimes, some reports, talking about cognitive impairment that could happen with ECT. That is debatable. Sometimes the actual selection of patients for ECT means that we get sicker patients generally to do ECT. And we know that, patients with severe mental health issues like refractory psychosis or refractory mood disorders, they have the tendency to have late or more cognitive impairment late in their life anyways. So we're not sure if it's ECT that does that or the natural history of the illness itself. But that on the side, and obviously there is sometimes headache that could happen because of the electricity delivery to the brain. All right. So if the public is not very interested in doing ECT, but we're still suffering from a lot of depression, we gotta find better treatments, right? Something that is more acceptable and that's more easier to administer and doesn't have as much side effects. And here comes TMS, or Transcranial Magnetic Stimulation. So transcranial means through the skull. Magnetic stimulation means that we're using a magnetic pulse to activate areas of the brain that are involved in the cycle of depression. Okay, so a patient will be coming to the clinic, they will be sitting on a reclining chair, and the magnetic coil would be placed on the area of the brain that is called the DLPFC, or the dorsolateral prefrontal cortex. There are different ways to measure and find out where the DLPFC is going to be, and that's going to be a topic of future videos. But basically, the patient is completely awake. They're either watching TV or engaged in psychotherapy during that time, or doing meditation or something of the sort. And there's no sedation involved, no anesthesia. There's no downtime. The patient can drive themselves in and drive back home themselves, after the treatment. The duration of a treatment session is between, used to be 37 minutes. Currently, almost all TMS machines are significantly more advanced, and they can cool the device, they can cool the coil in between delivery of the magnetic pulses much faster, which means we can cut this time from 37 minutes to only about 18 minutes or so, okay? So basically, the patient is here for about 18 minutes. We do that every day, Monday to Friday, 5 days a week for 6 weeks. So think about it this way. It's similar to if you're going to the gym to exercise and build up muscles. Are you going to lift weight only once and call it a day and expect muscle growth to happen? Probably not. Probably you're going to be exercising every day. You're going to be doing exercises in sets. So you're going to lift weight in sets. You're going to do that repetitively during that hour at the gym. You're going to do this daily. You're going to do this for a few weeks, and then you expect muscle strength to grow over time. All right. Okay. So what are the chances of responding to transcranial magnetic stimulation? All right, so that's another thing that is biggie, because oftentimes we tend to kind of get the headlines and say, oh, well, this protocol has 90% response rate, this clinic is doing 80% success rate, and what have you. We should be careful when we're throwing out numbers, because depression is a chronic illness, chronic disease, and we want to manage expectations to make sure that this patient doesn't feel like a failure. They don't internalize the failure in case that they don't respond to the treatment. So in open label trials, the number that is most commonly reported is 58% response rate. In naturalistic trials, you could see that number coming up to 67%. Even the most recent one, I think last year, was looking at like big data collection showing about 73% response rate and what have you. That's open label trials, okay? So there is a placebo effect happening in there, and placebo effect is huge in psychiatry and neurological illnesses generally. When you're looking at randomized control trials, then that number is significantly less. But what's important that is in randomized control trials, your goal is not to see the percentage of people who would respond. Your goal is to see, do they separate from placebo? Does the actual patients who are receiving TMS and the ones who are receiving a treatment that sounds like TMS but it's not really TMS, meaning that you put in a coil, but that coil is not delivering magnetic stimulation, it's just making some noise, right? So randomized control trials, showed efficacy of TMS in multiple well-designed clinical trials so far. Okay. So if a patient responds to the treatment, then we do taper off treatment. Taper off is 3 sessions in week number 1, and then 2 sessions in week number 2, and then 1 session in week number 3. Okay? All right. Now, some patients, we might consider doing maintenance TMS after that, meaning doing a treatment session every week or so? Who would we consider maintenance TMS for? In my practice, it's patients who are on their second course of TMS now. If somebody got a course of TMS, they responded, and then say 3 months, 4 months later, they had a second depressive episode, then after we treat them again with TMS, we might put them on maintenance TMS just to prevent a third course from happening. Usually we don't charge the patient for that. But that's just my clinic. Other clinics obviously are going to charge the patient for maintenance TMS. Insurance don't cover maintenance TMS, they cover the regular TMS course. All right. So then tell me about the side effects, right? So you just mentioned a few things about ECT. Is TMS completely free of side effects? Not really. There are a few things that could happen with TMS, but they're way less common than ECT or medications even, right? So, the main thing that we talk about is the risk of seizure. Seizure can happen with TMS. Seizure happens with ECT. It's the goal of ECT to induce a seizure. With TMS, we're not inducing a seizure, and a seizure is never a goal with TMS. But it could happen as a side effect. Let's say that the coil, instead of being placed in the frontal lobe, for some error, it's placed on the motor cortex, and that patient was sensitive, for such a placement, and that they could go into a seizure. How often does this happen? It's extremely rare. It's 1 in 30,000 treatment. And recently, some of the papers that are showing naturalistic data of data collection for many years now is showing that this number is even less than that. We're talking about 1 in 89,000 treatment. So the risk of seizure is extremely rare, but that doesn't mean that we don't screen our patients for it. So we need to see, if a patient had ever had seizures in their life, whether they had a recent head trauma, whether there is any intracranial bleeds, whether there was any seizure disorders, or whether they're withdrawing from substances, alcohol, etc. All right, okay, so, all right, that's reassuring, that the risk of seizure is extremely rare. What if it actually happens? Well, if it actually happens, it's not really life-threatening. It's similar to the ECT seizure. So what we need to do is stop the treatment, and then the seizure will go away in similar timing, 3 to 5 minutes, similar to what happens with ECT. I am not aware of any status epilepticus or any life-threatening situations that happens with seizures related to TMS. Okay. All right. Okay. So that seems to be kind of not common. What is common as side effect of TMS? Okay. Well, the common side effect that happens with TMS is headache. All right. Okay. So you're placing a coil that is delivering magnetic stimulation for about 2 centimeters depth into the brain. Okay. So that coil, those magnetic pulses are going to go through the scalp tissues and then through the skull and the skull and then to the brain. So sometimes this activation of the scalp in this area could cause some irritation that could lead to discomfort, and for some patients it could cause headache. That headache is reported between 20% in some clinical trials to even 80% in some other clinical trials. It seems like when you ask a patient, are you hurting? Like, yeah, there is something in there. So they will report it as headache. But if you separate headache from discomfort, most patients report this as discomfort. And if you're telling the patient, is this severe enough for you to stop the treatment? In most of the cases, it's not severe headache. I very, very rarely have a patient stop in TMS because of the headache that happens during the treatment. What if a headache happens? Well, usually it would go away after about a few treatment sessions because you get used to it. Let's borrow the example from the gym again. Remember when you were doing, exercises and sets, you might have some muscle soreness in the beginning, but then this muscle soreness will go away after about 4 to 5 days, and then you only keep the improvement in muscles after that. Okay, can we take something for the headaches, before TMS? Yes, you can take Tylenol, you can take ibuprofen in case that you're prone to headaches, usually with TMS, and that will help alleviate the headaches. And by the way, the headaches usually are happening during the treatment and just maybe 30 minutes or so after. It's not like you're going to have intractable headaches that would never go away and what have you. There is a debate about migraine headache. Not a debate. There is an FDA approval for a particular TMS device that is used to prevent episodes of migraine during the aura phase. So there is evidence that TMS could help with migraine headache, but the headache that I'm talking about is associated with the treatment itself. It's more of irritation, tension headache kind of thing. All right. Okay. So what else could be side effects of TMS? Well, there's the noise, right? So the machine is making a noise similar to an MRI machine. So if we're not protecting our hearing, our ears during the treatment, then tinnitus or ringing in the ears could happen, or hearing loss, or what have you. So if a patient wears foam earplugs, protection for their ears, that eliminates the problem basically completely. So all of our patients are offered, foam earplugs, to kind of protect their hearings. Okay. All right. What are other side effects that could happen with TMS? Well, there are some reports of, for example, lightheadedness that could happen with TMS. The problem, though, is that this lightheadedness in most of those clinical trials were found in both patients, in the ones who received actual TMS and the ones who received placebo. And it could be related to the positioning of the chair, So, when you're tilting somebody back and then they're sitting up, there is orthostasis that could happen, meaning that their blood pressure and heart rate could change because of the positioning itself. And there are some patients who could have benign positional vertigo, and then, the adjustment of their head could make the vertigo or lightheadedness, to be a little bit problematic. So I haven't really seen convincing evidence that this is related to TMS itself. It seems to be more related to the positioning of the chair itself. Okay, all right. How about memory? You told me about ECT. ECT has a problem with, could cause a problem with memory. Does that happen with TMS? No, there is no proof of that. I am aware of some folks who were going after side effects of TMS, trying to stigmatize TMS similar to how ECT was stigmatized in the past, and they claim cognitive impairments and what have you. In randomized clinical trials, which is how you prove whether there is a side effect of something or not, there hasn't been difference in neuropsych testing among patients who received TMS compared to patients who had placebo. I am not aware of any of that. Actually, there are significant clinical trials showing the opposite, showing that patients do have improved cognition with TMS, because you're activating the frontal lobe, which is the executive function side of your brain. So yeah, there is no evidence of cognitive impairment happening with TMS. Does that mean that it would never happen? No, I did not say that. I'm just saying that there is no clinical evidence, clear clinical evidence, that there is any cognitive impairment that would happen with TMS. All right, okay, so we know what TMS is, we know how it's done, we know the frequency, we know the side effects, potential side effects that could happen with TMS. All right, okay, so what other options do we have other than ECT, TMS? What else is available? I already mentioned esketamine. So esketamine is intranasal spray. A patient will be coming to our clinic. They will be sitting in a comfortable room. They will do intranasal inhalation in each nostril, and then we watch them for 2 hours in the clinic. So they're watched, throughout the time. We check on them every few minutes, making sure every 15 minutes or so, making sure that the patient is doing fine, and we check their blood pressure and what have you. So esketamine is also a medication that works on neuroplasticity, causing improving connections between brain cells, basically, as we do the treatment repetitively over time. So the patient will have to come to the clinic to do esketamine twice a week for a month, and then after that once a week for a second month, and then after that maintenance treatment for about once every 2 weeks. Some patients will need to go maintenance once a week, some once every 2 weeks, some once every 4 weeks, but the most common protocol is going to be once every 2 weeks. What are the side effects of esketamine? Well, dissociation. So patients will feel a little bit out-of-body experience, a little bit high. It happens in about 80% of patients. It happens usually in the first 30 minutes, but we still monitor the patient for the whole 2 hours. Heart rate could go up, blood pressure could go up. So that's why we check blood pressure and heart rate before, after administering the treatment, and before we clear the patient for discharge from the clinic. And obviously, with anything that could cause high or could cause, dissociation and things of the sort, there is risk of abuse. But abuse is not really that likely with esketamine because it's done in a controlled environment. You can only do it in the doctor's office. So it's unlike if you're taking pain medications at home and you take them when you please. That's not the case with esketamine. You cannot really do it at home. And I discourage anybody to see a psychiatrist who would write you oral ketamine to take at home on your own or what have you. That is extremely risky, and that is going to lead to another pandemic, another opiates problem similar to what we had before. Okay, so no, there is a risk of abuse, but if it's done in a controlled environment, you should be fine. And then obviously, you know, if somebody is in a childbearing age, we want to make sure that they don't get pregnant, because we don't have good safety data on babies, you know, during esketamine. All right, okay, so we talked about ECT, TMS, esketamine. Is there anything else that's FDA approved or in the process of FDA approval? Yes, there is a vagal nerve stimulator. It's a treatment option that is available as well, which is a surgical implant with a stimulator, the battery back in the chest, and a wire similar to the one that we would use, or you know, kind of somewhat similar to the one that we would use as a pacemaker, but instead of going to the heart, the wire would go to the neck, and it connects to the branches of the vagal nerve, and it would stimulate the vagal nerve, which was originally a treatment for seizures, and then it was found to help with depression, and that is, you know, being investigated even farther currently to see if that's how helpful that is. Okay. All right, so this is generally, in summary, the treatment options that you have available today for depression. Almost everything I mentioned today is FDA approved or cleared or being readdressed by the FDA. There are so many other things that you can read here and there that are not FDA cleared, or they're not actually do not have that much of evidence. For example, psilocybin is being studied now, you know, and all kind of other psychedelics that are in clinical trials now. Once those become available, trust me, you'll be updated about that. Okay, well, thank you very much for watching. If you have questions, you can list them or send them via our website, and I'll try to answer them. Quick disclaimer before I leave you. Although I am a psychiatrist, this is not a professional advice, as I am not familiar with the uniqueness of your case. Please contact the psychiatrist in your area with more questions. This disclaimer is added to my answers on social media after consulting with the American Psychiatric Association. And if you have any questions that you would like me to answer, you can either submit them through our websites or leave them in the comments. I'm gonna try to make some videos every couple of weeks answering questions that are related to treatment-resistant depression or TMS. Thank you.